side.
She's been trying for it.
I'm not gonna be standing here the whole
Oh,
time.
you're gonna-
I'm gonna move.
Sorry.
Yeah. No, I'm gonna move. No, that,
Oh,
you can
no,
use that one, but I'm gonna be
no,
moving.
just to move down in case someone came.
Oh, that's very kind of you.
Okay, I'll talk about like the different fibers. And I'll talk about that. Just wait till I'm done.
Yep.
Then I'll-
So which way can't I go to?
Let me come back and check.
Is it still cold out there? His blowing has gone down now? That's good.
We're trying to record this so that we can put it online, so if you wanna watch it later, you sure can. You're fine, Dr. Martins, when moving in?
Right here's
Yep,
fine?
you're good, and you're fine, Dr. Goplin, go!
Not yet.
Not yet!
What do you need?
1 minute. I just need a sip of water.
Oh my
They just don't ever listen to
Boys,
me.
they're needy.
I'm the office manager and they really don't listen to me. It's a sad state of affairs. Jeez.
I just need to get a sip of water.
All right.
I've been talking all day long, my throat's dry.
I'm ready if you are.
All right.
Okay.
Well, my name is Dr. Martins. It's Dr. Goplin. We're both chiropractors here at Optima Health. Some of you here are familiar faces, some are not, so I'm sure some of you never have seen either of us before.
Welcome.
Yeah, welcome. Both of us are trained, licensed chiropractors. We also have training in functional neurology. Difference between functional neurology and pathologic neurology, kind of like what you'd see with the medical profession, is that we deal with things hopefully before they become pathologies. Okay. We also look at the function to how the body's working, and we want to make it work more optimally. Okay. So we've both gone through a lot of that training, and also various other trainings with like doing brain mapping and neurology in that sense too. So
I don't know.
that's a lot of some of our background, and also a little bit
Rehab.
more rehab. Some of my background is in doing rehab with people who've had strokes, deal with MS, heart attacks, and things like that too. So,
And nutrition.
yeah, also a lot of nutritional type of stuff. So.
Whole picture.
The first thing I just want to kind of talk about is the difference between traction and decompression, okay? A lot of people have heard of traction or heard of decompression. Traction is the force of actually kind of taking someone, and what we're doing is we're creating a separation of the discs, okay? It's traction therapy. Decompression therapy is something, or decompression surgery is when they take, and cut into you, and it's spinal decompression, and a lot of times what they'll do is actually replace discs, okay? So I just want to basically separate those 2 points of traction versus decompression, okay? Both of them relieve pressure off of the nerves on the spine. The peripheral nerves are the nerves that come directly out from each spinal column, okay? So they sit on each other they sit on top of each other like a block, and decompressing is separating to take pressure off of those nerve roots, okay? Think of your nerves like a highway, okay? Right when they come out of the vertebrae, that's the major highway. They branch off, it's kind of like by roads, okay? If you cut off that major highway, you're going to cause abnormal function down the other roads too, okay? As you can see there's a couple of pictures of someone on traction therapy, or different types of traction tables, similar to what we also use here. One of them, someone's doing lumbar traction, the other one, the person's doing a cervical traction for the neck, okay? And towards the end, if you guys want to, at the end of the talk, I will show you our different traction tables. We got 2 different types for various different reasons. Here's a couple example of discs, herniated discs. Some of you have maybe seen MRIs or an X-ray before. I'm just going to kind of show you exactly what they're looking at. MRIs are typically looking at water content of a disc. So the top one there, this is an MRI. This is an MRI, okay? Specifically what's called a T2 weighted image. You don't need to know that, that's for a radiologist. But what it's looking at is mostly the water content of a disc, okay? Discs are not very vascular, which means they don't necessarily have a very good direct blood supply. Most of their healthiness comes from osmotic pressure change or a negative pressure change in that disc, and it draws fluid and minerals and other nutrients into the disc, and then pushes out the old stuff, draws in the new stuff, okay? So it kind of works like a pumping mechanism. Ones that don't get a lot of that new fluid and nutrients into it, those discs start to degenerate, and that's what you're looking at in these MRIs. So I'll just point out here real quick. Here's an x-ray. You can see right in between here, this is where the discs would be, okay? Where those discs are, these would be somewhat healthier ones. They got a good space in between each one, right? You can see down here, the very most bottom one, there's really no disc space there. So based on an x-ray, we could probably say this person possibly has a herniated disc, and it's probably not very healthy, okay? Now, these are not the corresponding MRIs to go with this specific x-ray, okay? If you're looking over here at these MRIs, both here and up there, you can see the nice discs right up there. Those are nice and white. Those are healthy discs. They're separated really far. No pressure on the nerves, more than likely, okay? The bad disc is the black one here. So you can see that, right? Because it doesn't have a whole lot of water, the nutrition out of it's gone. That's a disc probably waiting to herniate and collapse, okay? It actually, if you look at it really closely, it does have a small herniation in it already. Where this one is showing a good herniation, okay? So, good disc, starting to get bad, small herniation. The bottom one, even darker, bad disc, larger herniation. Someone's probably gonna feel pain from that, okay? So that's just the quick basics of how the discs function.
And how we see it on images.
This is just a cartoon rendition of what the discs look like again, okay? The top left one is a healthy spine, healthy discs. The run on the top right, that is basically arthritic spine. So there's osteophytes, things like that, bony spurs coming off it.
Loss of joint space.
And loss of joint space. So the person's having degenerative disc disease. Some of you may have heard that term. And what that's going to do is create, again, a bad disc. So in the bottom left-hand picture, you can see down where the nerve is kind of fired up, and that's because it's kind of being compressed upon, okay? Not all discs, I just want to clarify this real quick, not all discs have to actually have a bulge disc pushing on it. That's, a lot of people got that in their mind. It needs to be a bulge actually pushing on a nerve to cause a pain. What they found out about 20 years ago is that discs have a defensive mechanism when they get irritated. So if you ever hear the term hot disc or flared up disc, that's when a disc is irritated, and what it will do is actually release a chemical, and it's an irritant. Okay, that irritant will irritate the nerve and then send nerves to fire and cause pain. So it's kind of like, I don't need to come by and poke you guys in the eyeball for your eye to hurt. If I sprayed pepper spray in the air, it would irritate your eyes, right? It's the chemical irritant that's irritating it. So
Don't worry, we left it at home today.
yeah, no pepper spray to demonstrate today. So.
Okay, so you might be wondering, how do discs stay healthy? Well, they stay healthy through proper nutrition and diet and hydration. So you can see that right up there. How do they do that? How do they get hydration and that water from our tissue and our body to go in them? I think of the disc as like a jelly-filled donut that sits in between our bones. So it needs to be nice and cushy because it is our shock absorbers for our whole upper body. And how do we get that nutrition and hydration into the discs? Well, through decompression or a traction device like we're talking about. But even before you may experience symptoms, it's good regardless of whether or not you're experiencing pain, because through that gentle stretching, it creates a vacuum effect for that disc, and that's how it sucks and pulls those nutrients and hydration in from our body. As well as movement, gentle movement. We don't have a Pedibond chair here, but just if you were to sit on one of those big therapy balls and do like some hip circles on them or side to sides, those are really, really good to help move and mobilize those discs, and it kind of just helps create that effect that they can suck in those nutrients. So they're kind of like little suckers. So yeah, and through proper movement, like I just displayed, and proper diet, that's how they stay healthy. Okay. So symptoms that, come on in, pick a chair.
Sit right there.
Anyways, symptoms that are produced by a poor nerve function,
Sounds good.
as you see here listed, neuropathy. Neuropathy are things like you might be experiencing like numbness or tingling in your feet or hands, neck and back pain, sciatica. Sciatica is a term that many of you may have heard. It's a big nerve that exits right in the middle of our butt cheek, and if it has compression or someone's irritating it, it can send pain all the way down our legs. Knee pain and poor balance. So it's a big circuit of basically our low back and the nerve supply that exits there that goes down into our legs. And if we start to see compression or what we just saw in x-rays and MRIs where something is literally bulging out and sticking into that spinal cord, you're going to get those symptoms. Now, that's not required to experience symptoms, but it's kind of a relationship that is commonly seen.
And that's just a small list.
Mm-hmm.
A few more of the
Big
common
ones.
So basically, when we're talking about, when we do an exam, we're going to check not only about the neuropathy going down the leg, but specifically if you have like peripheral neuropathy or loss of sensation down the leg, or it might be down the arm, because everyone thinks of it, in the lower back, but it can happen in the neck too. You can get it down the arms. We want to know what else that's going to be affecting. So during our exam, we also check the neurology all the way from your head to toe, okay?
Yeah.
Right, yeah, head to toe, one of the ways. So the reason why we want to do that is because we want to make sure your motor control is normal and everything like that, because abnormal sensory input going in, so every time, like if I tap my arm, that sensory input going all the way up to my brain, if that's abnormal, eventually that's going to send out abnormal efferent output. So motor output or movement going outwards. And we want that to be normal, okay? Because if you all of a sudden have abnormal motor output going on, you might cause other problems in the future. You start limping with this leg and someone all of a sudden, I got lower back pain with this side, and it's because of, it's just a cascade effect, a domino effect that can sometimes happen. But also, just, for good brain health is to make sure that stuff is balanced well too. So just to give you a quick example, this is an example I like to use when I talk about the peripheral neuropathy and how it can affect the brain, because no one's like, well, if I got lost of sensation in my leg, how's that going to affect my brain? I don't know how many of you here have heard of phantom pain or phantom leg syndrome. Has anyone? A few of you? Okay. So just to give you an example, if you haven't heard of it, think of someone who is about 40 years old, have both legs their entire life, right? All the time, air, pants rubbing against, someone kicks them in the shin as a kid or whatever. That's all information being sent in through that leg, going all the way up the body, goes in through the spinal roots, goes up the spinal cord, hits an area of the cerebellum, goes across the medulla, and up to the cortex of the brain. So you can see up there, it's going all the way up to the cortex of the brain. Depending on what part of the body it was, different cortex, okay? So you always have that sensation going in, boom, 270 miles an hour, that information is being sent, okay? All of a sudden you're 40 years old, something happens, and let's say you lose your leg below your knee. Now you don't have that sensation anymore. So phantom pain syndrome is well, why does someone still all of a sudden once in a while get an itchiness or feel pain in the leg that's not there? It's because the brain still has those connections, okay? It still has those remembering, those feelings and everything like that. The longer someone goes without that leg, the less that will happen, that phantom pain syndrome. Because if you don't use it, you lose it, kind of a thing, right? So, again, if you don't, I don't want to say, you're missing a leg, but also you have decreased sensation down your leg because you have neuropathy. So you're losing that sensation, okay? Again, that sensation is not as strong or it doesn't happen as frequent, and it's going to go up and fire to the brain. If it doesn't happen that much because of loss of sensation, your brain doesn't use it, it loses it, okay? So we want to make sure proper input to the brain is happening too, because that will only strengthen this, but also prevent other domino effect types of pains or something like that
knee
happening.
pain,
Does that make
poor
sense?
balance, stuff like that. And I think what might help make a better picture too is that everything is literally perceived in the brain. So that pain we feel in our ankle, it's being perceived in our brain. It's the control center of everything in our body. Every cell processes and function starts and ends here. So that's why we do a very thorough neuro exam, checking to see how your brain's talking to your body. So we want to make sure you can feel those toes. We want to make sure you can feel light touch on your legs, because that needs to be pristine in order to keep a healthy brain and healthy body.
Specifically, a lot of times what happens when you start to lose sensation, like neuropathy in the feet, it affects what's called your large diameter afferent nerves, okay? These are your larger nerves, they're the myelinated nerves. They are the biggest functioning, probably, nerves for sensation in your body, okay? Those are going to be affected big time, and one of the therapies we do directly stimulates those large diameter afferent nerves, okay? Also, what are affected are small diameter afferent nerves, which are classified into two different types, A delta and C fibers. There is a test, so you better write all this down. No, I'm joking. But the C fibers have to do with dull achy, so anytime you have a dull achy pain, that's a C fiber firing for you. The reason why I'm stating this is because it's not all sensations follow the same pathway, are the same reaction, okay? So we test different things like sharp sensation, dull sensation, see which ones are being affected more, okay, during your exam. A delta fibers are more your sharp fibers, and those are usually more with acute pain, your more recent pains versus a chronic pain.
You can point to it. My shoulder hurts right here versus it hurts in here somewhere. That's kind of the difference of those fibers.
And those are the ones that will sometimes actually, well, most of the time will also be refired first, and they go through a remyelination process during the therapy too. So, and then that also has to do with that sensory input I was talking about earlier. When you lose that sensation in your leg, it's probably either large diameter. It's more likely usually that large diameter afferent, but it can be also the small diameters. Okay.
Okay, and I have something on our whiteboard that I want to show you that ties into this. Like, why are we talking about all this input business? Because here is the segments involved in our sciatic nerve, which goes down our leg. Okay, so we have L4, L5, S1, and S2. Basically that really big area right here in our low back. Okay, they all come together, nerve roots come together and join one big nerve, that sciatic nerve I talked about before. Okay, so then it travels down until we get to the knee. And then the knee is another branch off, and it makes the common peroneal. You don't have no names or anything, but this is what's going to travel down our leg, and it splits off even further into superficial and deep nerve supply. And it kind of demonstrated in this foot here, which is a really bad foot, I apologize. But so there's your big toe and a little toe that wings out that way. But so L5 is tested upon this, big toe through about your fourth. And that's why we'll do a touch test on that area to make sure you can feel that. And then that little web of the big toe area is a deep peroneal nerve. And then the outside of the foot where that little pinky toe is, that's the S1 nerve supply. So you can see how we want to make sure we address the low back, and if any of that compression is happening there, it can be affected all the way down that nerve pathway. So that's why it's important to look at the whole picture and why we do a neuro test. Anything else to add to that?
No, the reason for the neuro test is specifically because if we do sensation over here on the outside of the foot, and there's no sensation there, but they got perfect sensation here, we know it's probably coming off the S1 nerve root. So the first cervical navel root, which means it's more than likely at L5, S1. That's the very most bottom disc that's probably being compressed. I would say over 90% of the time, I can tell someone what their x-rays look like without even having an x-ray done. Okay. There's just a small percent of the time where you can't. If you do a good enough exam, you shouldn't need an x-ray, you shouldn't need an MRI. I mean, why spend $1,500 on an MRI if you don't need it? I usually tell people, if for some reason things don't get better, then maybe we'll get an MRI then. But typically I don't usually do an MRI to start. So.
Okay, so cerebellum function. So that's what we talked about with the large diameter afferent nerves, so the really big guys that send a bunch of information. Our cerebellum is a part of our brain right here. Very, very important in balance, coordination, and movement of our limbs. So again, going back to sensory input, so the sensory input going into our brain, the control processing part takes place in the cerebellum, and then the cerebellum has to kick out that motor input. So basically, message goes up, cerebellum sorts it out, and then kicks a signal back out to, oh, move my arm, it's hot, the shoulder's hot, kind of thing. So, you know, when we have poor function in our feet, loss of sensation, you kind of get the pattern here. It's a poor effect for our cerebellum. Then our brain starts to get unbalanced. And hemisphericity can happen, basically meaning you might have a left weak cerebellum, causes issues further down the line. So further in depth here, just as the cerebellum helps coordinate and plan the next sequential movement in a fraction of a second, so it's really, really fast, while the current movement is still being executed, i.e. walking, running. So that's a lot of coordination it does very, very quickly. When you start to have breakdown, you start to feel less balance. You might start to look down at your feet more, using, you know, walkers or canes because you don't feel as balanced. That's this guy, getting on low on fumes, we'll call it. Anything else to add to that, Dr. Martins? Okay. So moving forward, you know, what types of treatments do we do here for patients with these types of issues? Compression, poor nerve function, that sort of stuff. First and foremost, rebuilder. That is what Dr. Martins touched on earlier, which literally wake up those large diameter afferent nerves. It gives a constant stimulation to those nerves to help remyelinate them and get the feeling back in those toes and our hands, because it can happen in our hands as well. This is a picture again of that traction machine. That's also one thing that we use for our protocol, either on the neck or low back, as well as adjustments. So the primary things we want to do is we want to activate your nervous system by adjusting your spine, things like that. There's many different ways that we do that. You know, we alter to our patients. And then we want to do some therapy afterwards because our nervous system is at the most adaptable state to learning new pathways. It's basically the whole point of it is learning new pathways, which the brain can do. It has that ability. Thank the Lord.
And that's if we need some of those stuff. You know, we don't
Right.
necessarily saying that's what everyone's going to get is traction and rebuilder and all that stuff. I mean, I've had people with sciatic pain who don't need rebuilder and don't need traction. Because, I mean, you can get something called piriformis syndrome where it literally happens right in the butt area and it's not coming from the spine.
Mm-hmm.
So I just want you to know that that's not to say, hey, that's going to happen with everyone. But that is a common thing if it's a spinal problem, okay? Now she talked the two biggest things for, you know, re-stimulating nerves is fuel and activation. Dr. Julie just talked about the activation part, the stimulation. This is the fuel kind of, you want good fuel going to those nerves. Nerves just don't die off by themselves typically, right? They need good blood supply to them. That's the fuel. You know, if you get cold feet, it's probably got less, you know, decreased blood circulation to your feet. Decreased blood circulation in your feet can be very many reasons why that causes that. Possibly high blood sugar, type 2 diabetes, things like that. And what that's going to do is literally damage the nerves. If you don't feed the nerves good nutrition, they die too. Okay. Mm-hmm. So the fuel part is you know, sometimes we give people certain things to increase circulation. You know, basically re-stimulate that good blood supply, dilate the blood vessels, help regenerate those nerves, okay? Because if you just have the stimulation, you don't have the fuel, you know, it usually doesn't go as fast. So fuel and activation, important things to re-stimulating nerves and helping with neuropathy or any other type of thing like that, okay? Just real quick, I mean, the special for this is if, you know, people want to do having problems with neuropathy or sciatica or any of those other problems, we are offering an exam at a discounted rate at, I believe, $60. It includes consultation, musculoskeletal and neurologic exam. It also includes x-rays if needed. If not, we don't do them. Report of findings, so we'll go over what we found the next time.
And a plan.
And then that's about it, and then we'll just kind of go through your treatment with you and figure out what works, also best with you too, so.
So basically, if you're interested in just finding out a little bit more about things that you might be experiencing and want to have an exam, it's all you're signing up for.
I have a question.
Yes.
If I know for sure I have this, is it curable?
Neuropathy, it depends on the person. Without doing an exam on you, I can't tell you that for sure. I can just tell you, it's really good success rates with neuropathy, especially, things like sciatica. Just unbelievable results. I've never failed at one sciatic case, so, other neuropathy cases, really great results. Everyone's different. It depends where you're at. If you've had neuropathy for the past 80 years of your life, that's going to be a little more difficult.
And it depends on what metabolic state you're in too. Like if, we do a little bit more comprehensive of a profile than if you have other metabolic issues that might need to be addressed. Like if you have blood sugar control issues or inflammatory diseases or just processes. We try and like to encourage that you take a little bit better look at, diet and nutrition. Because those, putting proper fuel in helps get better results on the outside too.
Can I ask the question, does neuropathy always come from the pinched nerve?
No, it doesn't always come from pinched nerve. It's a common thing that it can happen, okay? But like, we said earlier, it can also be because of poor blood supply to an area. So if you have type 2 diabetes and you're losing some of that blood circulation to your feet or your hands, that could be the cause also.
And not all neuropathy is from diabetes. That's a common thing people think, but it's not. You don't need to have diabetes to get peripheral neuropathy.
Does Medicare cover this?
Medicare, it depends. Everyone's got different coverage with Medicare, so I can't. I can talk to you later afterwards, and we can discuss that. But I can't just say in general yes or no. The initial exam. It should, I don't know, I can't answer. Like I said, I just can't answer that. I don't deal with insurance. My job is to treat.
Medicare, the only thing we know for sure Medicare covers is spinal adjustments. Now it depends on if you have like Medicare A, B, or other.
You may have secondaries, things like that.
Yep, and sometimes secondaries kick in and pay for the therapies as well.
For this initial appointment though, these initial 2 appointments, you would pay $60 flat.
Yep.
It's not submitted to your insurance.
Right.
But after the first appointment, you'll be giving your insurance information to our front desk at your first appointment. By the end of your second appointment, when you would be meeting with me, I'll be able to give you an estimate of how much your insurance will cover.
Yep.
Good question. Anyone else?
Any other questions?
How about acupuncture?
What about acupuncture
Yeah.
and neuropathy? I've had patients who've done acupuncture and neuropathy. I think it works well. Again, I'm sure you would have to see an acupuncturist to know whether or not, what specific cases they're going to help you with.
And we do have an acupuncturist in our office as well.
I saw that.
Yep.
I looked at the internet.
Yep.
And I've worked with him with like cases with sciatica too, where he's done acupuncture with people, so we do use acupuncture here if we need it. Any other questions?
All right, now what are the 2 fibers that we talked about today?
Yeah, here's the test. How fast do they fire?
Just kidding, guys. Just kidding. All right, well, if there's no further questions.